afternoon, everybody. Should have said good morning, but it's good afternoon. My talk is a very colorful talk. Unlike the previous slides, it's very colorful. Let me start with a case presentation. This 21-year-old male came to our hospital last month. He came with defective vision of 2 days duration, pain redness, no history of trauma or any surgery or any of the histories mentioned in the slide. So anterior segment, cells 3 plus, flare plus, fundus not visible, P scan, cells severe vitritis, no RD or CD. Any point of time when I can't see the fundus at all, my three differential diagnoses are these. I'm sure the other steroidologists also will agree. It's acute retinal necrosis, toxoplasmosis, or a endogenous endophthalmitis. So the routine investigations, TCDC, CBC, ESR, MAN2, VDRL. Apart from that, vitreous tap was done, vitreous biopsy was done. This is for the endogenous endophthalmitis part. Toxoserology was sent, and from the vitreous tap, we eubacteria, panfungal, and all the antiviral, all the viral genomes and MTB genomes were sent for PCR, and culture was also done. So the patient was started on injection Magnex, which is a combination of ceftriaxone and sulbactam, covers with broad spectrum antibiotic, and topical steroid and topical antibiotic. On the second day, the patient was taken for a vitrectomy. Patient was given patient was given ceftriaxone and vancomycin. And the surgeon, Hemalata, she is here. She saw, she mentioned fungal balls or filaments suggestive of a fungal etiology. And so rightfully after the surgery, we started the patient on oral and topical antifungals as well. By then the cultures have started appearing. Blood and urine cultures are negative. So the vitreous culture shows Staphylococcus aureus. It was a good growth, madam, according to you. And the PCR for toxo and the viruses were negative. So my definite diagnosis at this point of time was endogenous endophthalmitis, mixed etiology, bacterial and fungal. You cannot ignore the clinical finding of observing fungal filaments or fungal balls in the vitreous. So the patient was completed 5 days of Magnex, and the patient was started on voriconazole, which is more specific for Staphylococcus. But he developed allergic reaction, so the patient was put on oral moxifloxacin. Last follow-up was on 28th of May, as you can see here. He's cleared up well, and he's still doing well. He's on the following medication. So I believe I will give him anti-fungal and antibiotic cover for another 2 more weeks. So my talk is on endogenous endophthalmitis. It is a rapidly progressive vision-threatening infection of the ocular tissues, much less common than endophthalmitis. It accounts for about 15% of all endophthalmitis. It occurs due to heterogeneous spread from some focus which is in the body and not from outside source like surgery or trauma. It is a rare complication of sepsis. People with either a bacteremia or a fungemia, they can have endogenous endophthalmitis, but it is rare. It is not a disease of old people, but still it occurs mostly after 60 years of age. And in the Western Hemisphere, it is more of a bacterial or gram-positive etiology. And in the Eastern countries, it is more of a gram-negative etiology. And also fungal endogenous endophthalmitis is more prevalent in the Eastern countries. So this publication is from the authors here have analyzed the NIS database, the inpatient database of the United States, where they have produced these results, 8,255 endogenous endophthalmitis cases, out of which 90 to 93% of them were bacteria, true to what was mentioned earlier. Number of organisms can cause endophthalmitis and endogenous endophthalmitis, gram-positive organisms, Streptococcus, Staphylococcus more commonly. What you see on top is a Streptococcus pneumoniae, the pneumococcus. Gram-negative organisms, commonly Neisseria and Neisseria meningitis, and other Klebsiella, E. coli, etc. What you see here is again a Diplococcus, which is a meningococci. And Candida is the most common of the funguses. Here you see two forms of Candida. One is the yeast form and one is the hyphae form. What is common for these are all commensals. They all reside within our body. The nasal cavity, the sinus, respiratory tract, skin, intestine. So whenever one loses their competence, immune competence, these can colonize it wherever they are, and from there they enter the blood and come to the eye and cause an infection. Endogenous endophthalmitis has been reported in COVID infections as well, patients affected with COVID, and these were the common organisms that were implicated. So, most common abscesses of the liver, brain, osteomyelitis, tooth abscess. These are the sites from where the bacteria or the fungi can enter the bloodstream and come to the eye. Infective endocarditis, HIV/AIDS, people who abuse alcohol or intravenous drug addicts, drug abuse, skin lesions, pneumonia and lung abscesses, in organ donor recipients, blood-borne, as I mentioned, fungemia or septicemia, old age, indwelling catheters, leukemia, lymphomas, any the renal system itself, abscesses or procedures done there, and diabetics and hypertensives. These people all are at risk of developing an endogenous endophthalmitis. Pyogenic liver abscess, Streptococcus species and Klebsiella, more common in Asia. Endocarditis, Staphylococcus aureus is the most common, and in India you can see there are in this study, out of all the endogenous endophthalmitis cases published in that study, 5.8% of them were due to infective endocarditis. And one more information from that study: if it's a native valve, then streptococci and enterococci were prevalent, and if it's a prosthetic valve or a cardiac device, any other cardiac device, it was a coagulation negative streptococcus that was the causative organism. Meningitis, Streptococcus pneumoniae and Neisseria meningitis. These two are very bad. Streptococcus pneumoniae secretes a lot of exotoxins and they can destroy the iris and ciliary body. Neisseria meningitis is sometimes very difficult to culture and can cause a delay in diagnosis. In the urinary tract infections, if any procedure is done without proper perioperative prophylaxis, then the possibility of an endogenous endophthalmitis is always there. Soft tissue infections of the skin or cellulitis are again risk factors. Osteomyelitis, intravenous drug use. In people with intravenous drug use, other clues can be either they might have liver disorder, viral hepatitis, HIV, infective endocarditis, or even septic arthritis. Indwelling catheters, again, the diagnosis sometimes may be easy because you have a catheter to, infected catheter to culture. So the symptoms are non-specific and it can depend on the site where the infection is from. Ocular symptoms can be pain, redness, photophobia, like what was seen in our patient. Disease is usually unilateral, but can be bilateral also. If it's a fungal etiology, it's insidious in onset, and whereas if it's a bacterial etiology, it is rapidly progressive. Signs anterior focal and anterior diffuse. The focal signs are anterior focal signs are iris nodules or microabscesses and AC cells. And the diffuse signs are severe inflammation with lid edema, chemosis, corneal edema with or without hypopyon. Posterior signs are again focal and diffuse, whitish nodules or plaques, usually in the choroid, that rapidly involve the retina. And as you see, the bottom part of the image shows you a diffuse chorioretinitis with intense vitreous inflammation. Evaluation, gram stain, GAMSA, KOH from ocular specimens. PCR is again sent, as I mentioned earlier, PCR, cultures. Samples can be taken from wherever you suspect the infective source to be. Compared to vitreous and blood cultures, aqueous culture positivity is very less. Keep this in mind always. Send for cultures, ask for cultures before initiating any antibiotic therapy. And the outcome of cultures, again, can vary from centers. As you can see in the publication above, 76% of the blood cultures were positive, whereas in the other report, they had a positivity of 48%. Vitreous cultures, surprisingly, in the first study was only positive at 19%, whereas in the study below, it was in 42%. And if a pre-culture antibiotic was given systemically, then all the cultures turned negative in the study. Other investigations are an ultrasound, chest imaging, if you suspect endocarditis, echocardiogram, and checking for immunocompromised states. Treatment, topical steroids, and cycloplegics. Chorioretinal infiltrates with no or minimal vitritis may be managed with systemic antibiotics alone and with close observation. But if they progress further, you cannot see the vitreous and a mild disease is becoming severe disease, then these people will need intravitreal antibiotics, a vitrectomy, and a vitrectomy. So the treatment protocols, bacterial, vancomycin and an aminoglycoside, as you see here, and a third generation cephalosporin are ideal antibiotics to start treatment with. It treats not only the systemic infection, but also has a reasonable penetration into the eye as well. I'm sure you all are familiar with the doses of antibacterial drugs intravitreally. I've updated this systemic fungal therapy from the recent Wilson manual. Fluconazole and voriconazole is what we give commonly. First choice of drug is fluconazole, 800 milligram orally. Loading dose is once in a day, one loading dose, and then 400 to 800 milligram orally once daily. Minimum for a period of 2 weeks or 3 weeks or 4 weeks. You decide on how the patient is improving clinically. Resistant or not responding to fluconazole, then you move to voriconazole. The doses described here. And not responding to both these drugs, then you try amphotericin. So intravitreal doses of amphotericin B and voriconazole are given here. And I think I forgot to mention in the previous slide, azoles are less toxic and produce higher levels in the vitreous, voriconazole and fluconazole. So pars plana vitrectomy in those with moderate to severe vitritis, vision is counting fingers or less, progressive disease despite systemic therapy, and performing a vitrectomy always improved the prognosis of final visual acuity and decreased the risk of progression to enucleation. Vitrectomy using an intraocular irrigation solution containing mixture of vancomycin and ceftazidime also has been advocated. This is a very interesting study I found, a possible relation between lack of PVD and severe endogenous endophthalmitis. These authors published details about 10 patients, very severe inflammatory findings. Vitrectomy was done in all the patients. A PVD was not found before surgery in 8 out of 10. And 4 out of those 8 patients, or 4 out of those 10 patients, developed severe retinal necrosis. So an attachment, the vitreous is attached to the retina, then there are more chances of a very severe infection, also hitting the retina and causing retinal necrosis. The findings suggest contact between retina and vitreous body may be associated with a severe disease. Why? The vitreous as a gel is a good growth medium, I believe, for all the infective pathogens. So the retinal surgeons, I think should, when you're doing a PPV, I think they should do not only a media clearing vitrectomy, I think they should also use a PVD and try to get the, the whole vitreous out. Follow up, you need to follow these patients up every day. I follow up my patients 2 times in a day. Morning, I see the patient, evening, I see the patient. The second day or third day off after intravitreal injections or systemic antibiotics, oral steroids are started. So once, see, we treat the infection, also the inflammation to be treated with oral steroids. So with oral steroids only, you will see a good improvement in these patients. So that will be evident only when you follow these patients up twice a day. Keep the patient in the hospital 2 to 3 days before you see a good improvement. You saw those pictures in my slide. Only when I see the fundus in that particular case of 1 or 2 down from 4, I send the patients home. And if the patient's on any, I might not like it, you need to do these blood tests, and the patient's on any ozoles, then you need to do these blood investigations. So I'll leave you with this. In this report, 32 patients of endogenous endophthalmitis, 8 patients were enucleated. In 8 patients, 8 eyes were enucleated. None received vitrectomy. 7 were bacterial, endogenous endophthalmitis, and 6 did not receive any intravitreal antibiotics. So these are the risk factors. So these are my references. Thank you.